Yeah. Hey guys. I'm Duncan, just like Will said. Yeah, I was actually in Annie's class at UW, so it was really fun seeing her. It was 2 years ago. And yeah, hope you guys are all doing well. I know this time of year it's stressful. But just remember, if Will can make it, any of you guys can make it. And so yeah, you will all be fine. And yeah, you will be really glad that you trained at UW because it's a great program. My talk today is on hyponatremia. Hopefully to give you a little bit of sort of a generalizable framework, but then a little bit more of sort of the fundamentals of how free water and solute are handled by the kidneys. I don't really have any disclosures other than I really like the kidneys. And these days, so I graduated 2022. I now work at Northwest in the ICU, predominantly doing like ICU nights, but then also do a little bit at Harborview in the aftercare clinic. So for anyone who wants to talk about career stuff or just wants to chat afterward, I'll have my email and would love to talk to all of you. And there we go. So I like doing hyponatremia. I actually developed this talk when I was in the sort of teaching elective, my third year. And it's because it's a complicated topic. And I remember especially starting out as an intern, it felt overwhelming. And I like sort of any topic that feels overwhelming, I like trying to break down into smaller pieces until I really feel like I have a sense for it. And I hope that after today, all of you will be feeling a little bit more confident in how to first diagnose the cause of hyponatremia, and then also some practical tips for how to treat it. Um, so today we're going to review ADH-based algorithm for hyponatremia, which is the one that I prefer because I think it gets a little bit more at the fundamental physiology that's happening. After that, we're going to zoom in on the ADH-independent forms of hyponatremia. So these are like tea and toast, veripotomania, a little bit on primary polydipsia. And the reason that we're going to do that is because I think it sort of illustrates the fundamental physiology between free water intake, solute, and then how that same physiology then applies to practical SIDH management. Because I'm sure you guys have all experienced in the hospital, this is sort of the one that, as like the primary team, this is yeah, a tricky one to manage, where patient sodiums will be stubborn. We're trying to bring them up, and I want to give you guys a couple other tools to use in that situation. And then we'll talk a little bit about patients that are going to be at high risk for overcorrection. And then if we have time, I'll also actually, there's some really interesting studies that are coming out that may be indicating that a lot of what we thought we understood about osmotic demyelination syndrome might not be the case, which is humbling, but good to review. So very briefly to start, we always sort of want to know what the symptoms of hyponatremia are. And as you can see here, they're kind of vague and hard to pinpoint exactly. And the reason for that is the only reason we care about hyponatremia is that hyponatremia is a stand-in for serum hypotonicity. And when when you have a hypotonic serum, that can lead to cerebral edema. And it's the cerebral edema that leads to all of the symptoms of hyponatremia. So starting just with sort of the run of the mill, just like I'm not feeling kind of great, maybe a little bit of nausea, vomiting, headache, all the way down to obtundation and coma. Like all of those are coming from the cerebral edema that's generated by the serum hypotonicity. And really, sodium is just a stand-in for that hypotonicity. And actually, like it's from like a practical standpoint, like on a BMP, if we could, it would make much more sense just to have serum tonicity be the sort of spit out thing for sodium. But just because sodium is a lot easier and more cost effective for us to measure, that's what we end up using. But there's nothing magic about sodium. It's just that it generally tracks with serum tonicity. And any questions about that before we move on? Because that blew my mind when I first learned that. And it also sort of we'll talk about in a sec. It's why, for example, like in DKA or cases of severe hyperglycemia, like the sodium is truly low. We just don't care because the serum tonicity is actually high in that setting. Okay, so moving on to the algorithm. I like this algorithm because it essentially has three questions, and for each of those questions, we have a corresponding test, and it makes sense from a physiological standpoint. So like we were just talking about, the first question we always should ask is, do we care about this hyponatremia? And for that, we always check the serum osms, because again, like sodium is just a stand-in for serum tonicity. And so if like the serum tonicity is normal or high, then we really don't care about the hyponatremia because it's not reflective of the thing that actually can cause cerebral edema. So a couple classic situations that you'll see this, obviously we have patients come to the hospital with hyperglycemia all the time, and that's a dilutional hyponatremia. And in that case, like the serum sodium is truly low, but we don't care about it because actually the serum tonicity, because of all that glucose that's trapped in the extracellular space, is actually raising the serum tonicity. And so it's not a true hypotonic state. And then similarly, we can also have this with pseudohyponatremia. This is with patients who have, like, for example, very, very high lipid levels, very high triglyceride levels, sometimes paraproteinemia in the setting of certain cancers. But that is actually, the osmolality will be normal. And the only reason that sort of the sodium is appearing low is because it's actually like a lab error within the test. So we always check serum osms because we have to figure out, like, is this actually something that we care about? And then if the serum osms are actually low, like, yes, this is a hypotonic serum, we are at risk for cerebral edema, so we should care about this. And then the second question we ask is ADH, antidiuretic hormone, activated? So ADH, it places aquaporin channels in the collecting tubule, I want to say. And so it's responsible for free water resorption. Um, and so in order to see whether or not ADH is being activated, we look at the urine osmolality. So if ADH is activated, the kidneys are trying to pull back on free water. And so the urine itself will be very concentrated. And so in terms of like which algorithms use like a cutoff for urine osms, you'll see a couple of different things. I sort of go with anywhere from 100 to 200, and it a little bit depends on your baseline kidney function, which we'll talk about in a little bit. But if you are looking at someone who's hyponatremic and you look at their urine and it's like dilute and the urine osmolality is low, those are ADH independent causes of hyponatremia, and they typically fall into the category of primary polydipsia, tea and toast, and beer potomania. And we're going to come back and spend quite a bit of time talking about those because they really illustrate the important physiology. But for most of our patients in the hospital, our urine osms are going to be high, and that's saying that ADH is activated. So the kidneys are trying to hold on to extra free water. The urine is going to be concentrated. And so something is telling the kidneys that they need to pull on, like sort of retain as much free water as they can. And that's where we sort of have to ask the next question of, like, is this appropriate? Does this make sense for the kidneys to be trying to hold on to free water? And really what we're asking here is this a low perfusion state? Um, so in low perfusion states, the kidneys and the bodies will prioritize sort of, they sense a lack of perfusion to the kidneys, and that could be from hypovolemia or just from like cardiorenal syndrome, cirrhosis. Anytime the kidneys essentially aren't getting enough blood flow, uh, the body will sense that. It thinks that it needs more volume going around, and so it will activate ADH as a backup mechanism to maintain serum volume, and it'll just say, we can deal with the tonicity later. We don't want to die from dehydration from hypovolemia first. And so the key test here is the urine sodium. And the reason the urine sodium is helpful is because if we're truly in like a state of low perfusion to the kidneys, the primary mechanism that should be trying to retain sodium and volume is the renin-angiotensin-aldosterone system. And so if this is truly a low perfusion state, the RAS system should be activated. The kidneys should be trying to hold on to as much sodium and as much volume as they can. And so the sodium should be low in the urine. And so this is where we sort of fall into a lot of our patients in the hospital. And the reason I like using urine sodium is because the typical causes of this are hypovolemia. So obviously if someone's just dry, and that's the reason why their kidneys are sensing low perfusion, you will see a low urine sodium. But this is also where we get sort of poor perfusion states despite hypervolemia, like heart failure, cirrhosis, and nephrotic syndrome. And part of why this is helpful is I'm sure you guys have seen a couple of algorithms where we get the urine osms and then we try to do a volume status assessment. And it can be pretty tricky to determine if someone's like euvolemic versus a little bit hypervolemic versus a little bit hypovolemic. Whereas the nice thing for here, if we're trying to differentiate between heart failure and hypovolemia, that's usually something that we can do pretty reliably. And from the kidneys perspective, those are both the same thing because they're sensing poor perfusion. Okay, I'm going to stop here. Questions about this, because this is sort of, this general algorithm, this trajectory is important to understand. Let me see. I'll open up the chat here. Okay. All right, I'll keep going then. Um, okay, so like we were just talking about, typically, let me get back to my slides. Typically, in the hospital, you'll see low urine sodiums. If again, if we're falling into that hypovolemia or any of those poor perfusion states like heart failure, cirrhosis, nephrotic syndrome. If we see a high urine sodium, that's where we fall into this sort of, well, it's called the syndrome of inappropriate ADH secretion, where even though the kidneys are getting adequate perfusion, ADH is still being activated, and we have to figure out sort of why that's happening. And as we'll see, SIADH is a huge bucket. That's sort of a diagnosis of exclusion. But other ones that you can sometimes see in this bucket is hypothyroidism. I've looked, there's no like clear mechanism for how this happens, but it is true that people with like true, very severe hypothyroidism and mixed edema coma will often have hyponatremia with a high urine sodium. Not entirely sure the mechanism by which that happens. Um, thanks, Bill. And then adrenal insufficiency. And can anyone think of why adrenal insufficiency would present with a high urine sodium? I'll give this like 20 or 30 seconds for any brave person who wants to guess.
No aldosterone.
Yeah, yeah, exactly. Yeah, if you've lost the ability to produce aldosterone, you won't have that sort of final sodium resorption, and so you will present with a high urine sodium, and that's just because you've lost sort of the ability to make aldosterone. Perfect. Yeah. Okay. So, and oftentimes in the hospital, I find that we are sort of going back and forth between like maybe the urinosms are typically high for most hospitalized patients, and then sometimes you get a urine sodium that's maybe like 25, 30, a little bit in the middle. And so we're kind of going back and forth between like, is this just from their heart failure, maybe a little bit of congestion? Is there some other component of SIADH? And so there's a couple of things that I find really helpful in this situation. Um, Serum uric acid is one that I've started using quite a bit, and it's actually in a lot of the nephrology guidelines. When there is a poor perfusion state, serum uric acid, along with the BUN and some of our other traditional markers, often becomes elevated. And then in SIADH, for unclear mechanisms, it's often very, very low. So if you're kind of in the situation where like, I'm not exactly sure how to interpret this urine sodium, getting a uric acid can be very helpful. And then also just think about our other typical markers of poor renal perfusion. So you can get a FeNA, you can get a BUN to creatinine ratio that can give you a sense for the overall sort of renal perfusion. And then another situation where the urine sodium can be a little bit difficult to interpret is if there have been diuretics on board. And in that case, like an FE urea can be really helpful. And so we'll talk a little bit about sort of how we're going to manage SIADH in a little bit. But if you are sort of on wards, there's a sodium that you can't really explain. One thing I would recommend is looking at some of these other markers. And then the other thing is, it's always useful, like if an initial sort of set of urine studies, like the urine osmolality, urine sodium came back a little bit borderline, and like maybe you've done an intervention since then, like they got a liter of saline in the emergency department, always recheck because sometimes the situation can be a little bit of both. Like maybe there was a little bit of hypovolemia that was contributing at first, but now we're just unmasking sort of what is more of like a background of SIADH from some other cause. And so following up repeat urine sodiums anytime things like aren't quite fitting often can be really, really helpful. Yeah, okay, questions about this? Because this algorithm, I think, is a lot of what we do as the primary team in trying to figure out the cause. And I have found, again, some of these other tips to be really helpful in working up my patients. So I'll take a pause here in case people have other questions. Oh yeah, yeah, okay, Ria, yes. So the uric acid, so for example, like say we look at like for example the BUN to creatinine ratio, because when the kidneys are sort of sensing a poor perfusion state, they actually increase the concentration gradient in sort of the nephron. And so because of that, they're trying to hold on to as much free water as they can by sort of utilizing that really steep concentration gradient. And one of the things that comes with it is BUN in that process. So that's why, for example, in a poor perfusion state, the BUN to creatinine ratio often gets elevated. And one of the other things that will come with BUN is uric acid. So you can check a uric acid level, and oftentimes in poor perfusion states, the uric acid level will be high. It's also another reason why, like, if we're treating someone for gout, like when someone's acutely in the hospital, they're not doing well, like gout, the uric acid can also just be in the joint itself, or like if there's an AKI and poor perfusion on top of it, like it can be a little bit difficult to interpret that value. And then as for why, the uric acid is very low in SIADH, unclear in terms of the mechanism. You will oftentimes also see a very, very low BUN. Like I've seen BUN sort of like in the 7 to 8 range for people who have significant SIADH, and unclear exactly uh, what that mechanism is. Oh, okay. And Laura with a fantastic question about how you might interpret these people in CKD. And yeah, and it's such a good question. I think, can you guys see my cursor? No, you can't. But I'm pointing sort of at the osmolality. As the kidney gets older and as CKD progresses, our ability to both concentrate and dilute the urine decreases over time. So we'll talk about like in a healthy kidney what that range looks like. But just be aware that, for example, someone with severe like advanced CKD, the max they might be able to dilute their urine might be a urine osmoles of around 200 or so. And so even if they're coming in with a urine osmoles of 200, that might be like a primary polydipsia or a tea and toast kind of phenomenon. And it's just that their kidneys, because they have decreased function, can't dilute their urine any further than that. It's also like really common. So patients with kind of like end stage renal disease oftentimes will present with a urine osm around sort of like 285. And can anyone think of why that might be? Pause is a tricky one. Uh, yeah. So as kidney functions, yeah, exactly. As kidney function gets worse and worse, your urine osms are going to get closer and closer just to the serum osmolality. Exactly. Yeah, yeah. So essentially, the kidneys are just spitting out the same osmolality as the serum because they've lost the ability to sort of shift that in any way. And so, as you get more and more advanced CKD, just recognize that that urine osm is going to drift in that direction and towards around a normal serum, like the whatever your serum osmolality is. That's a really, really good question. And that's why it's also like keep in mind, like when you're trying to interpret these studies for someone who's like older, has CKD, like we often like tea and toast and someone who's like 30 and otherwise healthy, like that urine osmolality be right at 50, that maximally dilute urine. For people who are older or have more progressive CKD, that's going to keep drifting higher and higher and closer to the serum osmolality. Okay, great questions. Cool. Okay, I will move on because we got some other stuff to talk about. But if other questions come up, please just ask. We can come back to this because this is an important sort of important algorithm, important slide to understand. Okay, so next thing we're going to focus on are these ADH independent causes of hyponatremia. So again, this is where the kidneys are trying to dilute the urine as much as they can. We have a low urine osmolality, a dilute urine, and yet we still have hypotonicity. And so again, kidneys are doing the very best that they can, but fundamentally the issue here is actually an insufficient ratio of solute to free water consumption. And so when we think about solutes for the kidneys, the two primary ones are sodium and potassium, a little bit of chloride in there as well, and then urea. And like urea is sort of the byproduct of sort of amino acid breakdown. Protein consumption eventually gets sort of excreted in the urine as urea. And so in terms of solute intake, the things that are important are salt and protein. And then as we'll talk about a little bit, like glucose in the setting of hyperglycemia, or also if you're on an SGLT2, like that can actually cause a little bit of free water osmo or diuresis. And so that can also be like a solute that the kidneys use, and we can take advantage of that. And then very low levels of amino acids also sort of come out in the urine. But again, the majority of protein breakdown eventually ends up as urea. But those are the solutes that the kidneys can use in order to sort of excrete water. And so if we think about, like, let's say we have a typical 70-kilogram person, if they are eating like a standard American diet with like a typical amount of salt and protein, the kidneys have about 700 milliosms of solute to work with. And then we sort of think about, okay, with that solute load, how much free water can the kidneys handle depending on their ability to either dilute or concentrate the urine? So, for example, at a maximally dilute urine of 50 milliosms per liter, and just the little algebra is down here at the bottom. So with that solute load, we'll look at the maximally dilute situation over here. 700 milliosmoles of solute to work with. The kidneys can dilute their urine. Healthy kidneys can dilute their urine to about 50 milliosmoles per liter. And so that means that you can safely drink up to 14 liters of free water and not develop hyponatremia or hypotonicity if your kidneys are able to maximally dilute their urine. Similarly, if you're on the other side and you have limited water intake and your urine is getting maximally concentrated, you will be able to handle about as little as like 0.6 liters of free water and still maintain serum tonicity because the kidneys are able to concentrate and dilute the urine appropriately to handle that. Now, one of sort of like primary polydipsia is where someone, for whatever reason, like oftentimes there can be underlying psych illness where patients really are convinced that they have to drink a lot of water to accomplish something. If you go over 14 liters of free water in a day, despite your kidneys trying their very, very best and peeing off as much dilute urine as they can, you can still create hypotonicity. And then the other thing that this can happen is more acutely, like 14 liters is over the course of a day when the kidneys have a chance to sort of excrete free water. If you blitz the kidneys and down like 5 liters of water within an hour or two setting, like there are oftentimes very sad situations of like water chugging contests in like fraternities, or there's like a radio contest where this very sadly happened where patients acutely developed hyponatremia, developed seizures, and died from the cerebral edema. So maximally dilute urine, like for primary polydipsia, you have a pretty wide range, like a lot of free water intake, unless you sort of exceed that in a very short amount of time. Okay, I'm going to pause here again. Does this make sense in terms of the kidney using the sort of their ability to dilute and concentrate the urine? We have a solute load that's based on our salt and protein intake. And then because of that, we can actually, most people can handle a really wide range of sort of free water intake, and our kidneys take care of it. We maintain a totally normal serum tonicity. That's why the kidneys are so cool. That's a pretty impressive range of free water.
We lost your screen, Duncan.
Okay, yeah, I think my internet, uh-oh. Yeah, my internet cut out, but now it's back. I hope that doesn't happen again. Can you guys see where I am?
We now can see the screen, but we can also see the full, yes.
We're
We're
good.
back.
We're okay, we're back. Sorry about that. Yeah, I hope that doesn't happen again. Okay, so moving on. We're going to apply now those same principles to the other forms of sort of ADH-independent causes. So again, when the kidney is trying to do whatever it can to excrete free water and isn't able to. And so tea and toast and beer-potomania are still, like fundamentally, again, it's an inadequate solute intake leading to a narrower range of safe free water intake. Um, and one of my favorite jokes is that like a nephrologist sees one of my favorite jokes, but it illustrates something. A nephrologist sees a plate of pasta and all they see is a glass of water. And that's because carbohydrates, when they undergo like just typical breakdown and cellular respiration in the body, they don't produce any solute that the kidneys can work with. And so beer, potomania, and tea and toast, this used to confuse me. It's not necessarily that they don't have adequate caloric intake. It's just that because of the types of foods that they are eating without adequate protein, without adequate salt and sort of solute intake, like if you're just having beer, which has alcohol, which is broken down a different way but doesn't produce any solute, it has carbohydrates from the hops and the other things that are in beer. And so someone can be drinking a lot of beer and still maintaining their caloric needs. And so it's not like I used to get them very confused in my head, like, is this like a hypovolemia situation? Is like the tea and toast person just like not taking in enough fluids? It's actually not the case. It's just that they don't have enough protein and salt intake, leading to an inadequate amount of solute for the kidneys to work with. And we'll see how just changing up your dietary composition like that can actually lead to a very narrow range of free water intake. So again, we just went through like sort of what a typical solute load. So a standard American diet, say you're getting about 10 milliosms of solute per kilogram, again, protein, salts. With a maximally dilute urine, we can break down that sort of 700 milliosm solute load. That gives us about 14 liters of free water that we can take in, and our kidneys can handle it just fine. We don't develop hypotonicity. If, however, we have a reduced solute load, so this is someone who is only eating carbohydrates, they're only drinking beer, they're not having enough protein and salt in their diet. Now, despite the kidneys still doing the very, very best that they can, they only have that 70 milliosms of solute to work with in this example. And then all of a sudden, you can see how it would be very, very easy for someone to accidentally drink more than 1.4 liters of free water. And the kidneys are still doing the very, very best that they can. But in that situation, that amount of free water still overwhelms the kidneys and you develop hyponatremia because of it. Okay, I'm going to pause here and questions about that. And again, this example where I took it all the way down to a 1 milliosm, that would be on the low side. But you can imagine that even if you have 2 or 3, people can understandably, especially if you're drinking beer, which has a lot of free water in it, it's very easy to sort of over intake the amount of free water based on the solute that you have available to the kidneys. And then we'll talk about next how we can then apply this to SIADH, because it's the same fundamental principle. It's just in that case, it's our urine concentration that's set, not our solute load. All right, we'll keep cruising. Okay, so we just looked at the primary polydipsia, tea and toast, beeropotomania, which again, we're realizing was the fundamental issue was a lack of solute intake. And because of that, we actually had a very narrow, safe free water intake range. And then here, we're now going to sort of apply these principles to SIADH and hopefully give you guys a couple of practical tips. A little bit about SIADH just in general. If you'll notice, like it's a diagnosis of exclusion, but if you look at the nephrology guidelines, it sort of goes through everything that we just talked about on that algorithm. You have to have a low serum tonicity. You have to have ADH activated. They used a cutoff of 100 milliosms here. Some people use anywhere from 100 to 200. You typically have a high urine sodium because, again, the kidneys are sensing normal perfusion. It's not a hypoperfusion state. And then a couple other ones here that we talked about. If you're ever in doubt, use those other markers like serum uric acid, BUN often being very low. And then you can also look at like a FeNA or FeUrea if there's sort of diuretics on board that are making things more confusing. And then as I'm sure everyone has encountered, SIADH can happen for all sorts of reasons in the hospital. Anyone who has like something going on with their lungs. So in the ICU, I see this all the time, like infections, mechanical ventilation, asthma. Any insult to the lungs can cause a stimulus for ADH for reasons that we don't fully understand. There's a long list of medications that can cause this. Obviously, look out for SSRIs in sort of toxic overdoses, like with MDMA. This can also be a thing. A lot of sort of antipsychotics can also contribute. And then really, anything sort of like within the GI tract. So like nausea can often be like a really prominent stimulus for ADH, and even things like pain in the post-operative period, like those can also be significant stimuli for ADH secretion, which leads to hyponatremia. And so, and especially if you like go through this list, you can make a case for just about any one of your patients that you've admitted in the hospital have a reason for potentially secreting an inappropriate amount of ADH, which is why this is so tricky. But going into sort of like what we can actually do. So say if someone falls into this bucket of SIADH, like what, first of all, why is this happening and what can we do to treat it? Again, fundamentally, we still have an imbalance between solute and free water intake. But in this case, unlike beeropotomania, tea and toast, it's usually the preset urine concentration, not the solute intake, is the sort of the driving pathophysiology. And so going back, again, here's our normal situation. We had a normal solute load over here, 700 milliosms. Our kidneys were diluting to the maximum capability at 50 milliosms per liter. We had a really wide free water safe like intake range. You could drink up to 14 liters per day and still not get hypotonic. Now, in SIADH, we can presume that we still have a normal osm load. So say someone's still eating a typical normal diet, but now the issue is that our set urine concentration is higher because of some stimulus for ADH. The kidneys are sort of forced into concentrating their urine to a new higher set point. And in this case, I just used 500 for easy math. But again, in the same situation, someone can have a totally normal solute intake, But because of that set high urine osmolality, all of a sudden we're in that same boat where it can be really, really easy for a patient to over intake on free water. And this is why fluid restriction is still the cornerstone of therapy. And so this is why, like, even in a situation where someone has a pretty high set urine osm, if you're able to get them drinking less than 1.4 liters of free water per day, you will be able to sort of get them below that free water, that safe free water intake, and the kidneys will be able to gradually sort of pee off extra free water, and you will gradually get your sodium and your tonicity back to a normal place. The tricky part is like this 1.4 liters of free water, that's really hard. Like that's not easy for patients to do. And so this is why augmenting the solute load, and this is what we do with salt tabs, is also what we can do by increasing protein intake. And as I'll talk about, soluble urea can be a really nice tool. So let's say we have this patient, they're still stuck with this like set urine concentration because they have ADH from cancer or from some other stimuli. If we augment the solute load that they have to work with, now all of a sudden we have like a little bit more range for the patient to take in a little bit more free water, be a little bit more comfortable with our diet, and we can still nudge them below that tricky balance between free water intake and solute intake. And so I find this to be like a really patient-centered way of, instead of just like cranking down the free water restriction, if instead we really encourage sort of solute intake, and that can be salt tabs, that can be just really encouraging a high protein diet with the patient, or something like soluble urea, which I think is my next slide. Yeah, is another thing that I've found to be very, very helpful in the hospital. So, and this is actually now available at UW. It's available at Northwest. I think it's available at Harborview as well. But just a quick plug, like these are two different ways of augmenting solute load for someone with SIADH. Salt tabs famously just like kind of feel awful on the stomach. And so to get 500 milliosms of salt, which again can really liberalize your patient's free water restriction and can be very patient-centered, but taking in 15 grams of salt a day can be really harmful on the stomach. And then if you also have other conditions like heart failure, like that salt load can be a little bit tricky. Soluble urea, on the other hand, is two little packets that you take twice a day. It doesn't taste great. I've tried it. It tastes a little bit like urine, although I haven't had urine, so yeah, I don't know why I would know what that tastes like, but it feels like because it does have urea in it, which is sort of the primary thing in urine. But you can get a really robust solute load with something that is much easier for the patient to tolerate and also doesn't have the same fluid retention problems that salt leads to. And so again, like if you give someone 15 grams of urea twice a day, that extra 500 milliosms, even if they have a really high set urine concentration, that buys them another liter of free water intake. And I find that to be a very patient-centered outcome. And there's actually some really good data for soluble urea leading to improvement in sort of difficult SIADH and improvement in serum sodium levels. Okay, questions about that? Cool. Okay, I'm going to zoom through a couple other practical tips, and then I want to get to just a little bit of data. So fundamentally, SIADH management is restrict free water, augment solute load so that we can hopefully get into that safe window of free water restriction. A couple other things, just like in general, I guess this is sort of my practical approach. Address any reversible cause. So actually this CT scan on the left is a patient I will never forget from residency who had a very bad primary small cell lung cancer that was leading to significant ADH secretion. That was sort of her CT scan on the left. She initially was in the ICU because her sodium was very, very low and she was seizing. In this case, we don't really have a cause that can be readily reversed, but things that we should look for are like medications, other causes of pain, nausea, anything that we can treat to reduce ADH secretion. Fluid restrict, because again, that's primarily the thing that we're going to be able to do. Augment the solute intake. So again, increase salt, increase protein, encourage things like potato chips, anything that sort of feels patient-centered and something that the patient can do. Soluble urea can be a really beneficial thing. We talked about this, protein intake. And then another sort of quick thing is if someone has really, really tricky to manage hyponatremia from SIADH, and you're thinking about like, shoot, we're not really making any progress with free water restriction, I think we need to use hypertonic fluid. just look at the set urine concentration, the urine osmolality, because that will guide the tonicity of the hypertonic fluid that you need to give. So for example, oh man, this poor lady, she had I think her urine osm was set at like 700. So we initially started on 2% hypertonic before that urine osm came back, since it takes a little bit of time. And even that 2% was still below the level that her kidneys were concentrating in the urine. And so she was someone that actually needed the 3% to get above that sort of osmolality threshold and actually cause her to be able to raise her tonicity a little bit. And then a quick plug for patients who have other indications, loop diuretics and SGLT2s can also be a very helpful augmentation. And we'll talk about why in a hot second. But any questions about this so far? And I think another sort of, don't sleep on using the urine osms to guide hypertonic fluid can be very, very helpful. And you will see all the time, like someone not responding to a certain, like if they're just on crystalloid, and then you look at the urine osms like, oh, okay, that makes sense that they weren't able to they weren't able to improve their serum tonicity because we were giving them a fluid that was below their set urine concentration. And then a quick plug for why loop diuretics work. Again, ADH works by increasing aquaporin channels in the collecting duct. And so, but aquaporin channels are just a passive resorber of free water. And so if you use loop diuretics and you kind of wash out the really steep medullary concentration gradient, all of a sudden, even if those aquaporin channels are there, not as much free water will actually get resorbed just because the concentration gradient is lower. And so keep this in mind for anyone who's in the hospital and they're hypervolemic. Actually, IV diuresis, using an appropriate amount of diuresis and getting decongestion will not only improve perfusion in the right person, but also will fundamentally help the SIADH or the hyponatremia component, because again, we're washing out that medullary gradient and we're sort of, even if ADH is on board for another reason, it won't be as effective at resorbing free water. So keep that in mind. And also keep this in mind for patients where a loop diuretic gets held for whatever reason, and in the next couple of days, you see the sodium go down. Like it oftentimes can be because of that. And so you don't necessarily have to go chasing for some other cause, like that in and of itself could be the cause for the worsening hyponatremia. And then a brief plug, you'll see a lot more nephrology teams using SGLT2s for hyponatremia. This was a cool study that was done 2 years ago. And essentially they were randomizing people to empagliflozin or placebo. And they saw a significant increase in sodium levels with SGLT2s. And that makes sense because we're essentially hijacking glucose, and we're using glucose as another contributor to osmotic diuresis by causing the kidneys to pee out more urine. So this is a great option for someone who's in the hospital, has diabetes, and isn't on a SGLT2 for another reason. You can often get it approved by insurance, and you will see those sodium levels go up and no adverse events. And this is one where you often will see a more pronounced effect at lower sodium levels. Okay, we're going to zoom. I think we've got 5 minutes. I want to just briefly talk about why some of these patients can be at very high risk for overcorrection. And again, the reason we care about overcorrection is for osmotic demyelination syndrome, which can be irreversible neurodamage. And I'm just going to quickly zoom through the slide. But essentially, we used to think, and well, we still do, that the people who are at highest risk for osmotic demyelination syndrome are people who are coming in with severe hyponatremia, so people less than 110 on initial presentation are at the highest risk. It is much more rare if the sodium is above 120, but actually we'll show that there are some certain situations where it can still happen if you then have a period of prolonged hypernatremia afterwards. And the tricky part about osmotic demyelination syndrome is it's such a rare event that it's really tough to study effectively, and we'll probably never have a randomized control trial. The initial sort of fears about overcorrection being the cause of osmotic demyelination syndrome were from a couple of case studies in the 80s with surgical patients who had severe hyponatremia postoperatively in the setting of pain, postoperative period. They corrected their sodium levels by, I think it was an average of like 23 milliosm or milliequivalents per day, and they all developed osmotic demyelination syndrome in that study. And so from there, we got this like, okay, it's from rapid correction. We started walking our sort of correction rates back to sort of around the 8 milliequivalents of sodium sort of recommendation that we have today. But as we'll see, like the data doesn't actually isn't entirely clear that the rapid correction is the primary cause there. Instead, really keep your eye out for additional risk factors, and this has come up in sort of every study that's looked at it. People are going to be at the highest risk for developing osmotic demyelination syndrome if they also have alcohol use, cirrhosis, malnutrition, and hypokalemia is another one that often comes out. And we're just going to briefly talk about why ADH-independent states are ones that you really want to pay attention to because they are at high risk for correcting very rapidly. And then we'll get into just the one study that showed that maybe we didn't know quite as much as we thought about ODS. Okay, so briefly, these are the states that are going to be at high risk for overcorrecting, both the ADH-independent forms and then also hypovolemia. Hypovolemia is high risk for overcorrecting because as soon as the sort of you restore volume, the kidneys are no longer going to sense hypoperfusion. They're going to shut off ADH, and then all of a sudden you can get a brisk free water diuresis, and that can correct your levels very quickly. And then going quickly to the tea and toast beer potomania, and I especially want to sort of highlight that beer potomania, concurrent alcohol use, if they have liver disease on top of it, these are very high risk patients for ODS. And the reason that they can correct so quickly is, again, say they have normal kidney function, their kidneys are trying their very best to maximally dilute their urine. They show up in the ED, maybe they've got a sodium of sort of like 115, 116. They look kind of chronically ill. You're like, maybe they just like haven't really been eating and drinking super well. So let's give some fluid and see how they respond. So if we give just a liter of normal saline as initial resuscitation fluid in these patients, that's about a 300 milliosm solute load just in that bag of NS. And then if we factor that in to our dilute urine, all of a sudden these patients are going to start dumping out free water because with those kidneys, again, the kidneys are mad. The kidneys want to get rid of the free water as quickly as they can. They've been trying as hard as they can. All of a sudden we give them the solute that they've been needing this whole time, and they will just dump free water. And so these patients you have to be really careful of. Like I actually, when I see these patients in the ICU, I actually put a Foley catheter in because I really want to be able to track how quickly they are starting to produce free water or sort of like this very dilute urine. Because if we start seeing that, then we actually know like, shoot, we might be in this range where this person might correct by 15, 20 milliequivalents very briskly, unless we start taking additional measures. Okay, questions about that? Does that make sense? Because again, it all comes back down to that solute and free water balance. And this is why these tea and toast and beer potomania people can be very tricky. It's also tricky because for milder forms of hyponatremia, like this is a classic thing where in the ED, someone comes in and they've got like maybe a sodium of like 124, they get a liter of fluid in the AD and then it gets better on repeat check. And so the advice is like, oh yeah, you were probably just a little bit volume down, like go home and drink a bunch of water to sort of make sure that you stay hydrated. And that's the exact wrong advice for these patients. Because again, fundamentally, it wasn't a free water intake in a hypovolemia situation. It was a lack of solute intake for their free water intake. And so like if you're working in the ED or if you see this, keep an eye out for very dilute urine because even if you don't have a urine osmosis, the specific gravity can also give you a clue to this. Okay. I will skip this. This was sort of like if you're in the ICU, which is where I spend the most of my clinical time, you can use things like a DDAVP clamp, which can help prevent people from correcting too quickly because essentially you're giving them synthetic ADH that prevents the kidneys from diluting the urine. And I used to do a lot of this. I am still doing it in some cases, but I'm doing less of it now because there's actually recently, within the last couple of years, there's been a couple of large studies. This most recent one was from last year that, again, large data sets, well done retrospective study that was looking at over 22,000 patients with pretty significant hyponatremia coming into the hospital. Of all those 22,000 patients, only 12 cases of osmotic demyelination syndrome were identified. So first of all, very, very rare. And of those 12, more than half of them did not have rapid correction of sodium, which is in the study, they sort of determined that to be over 8 to 10 milliequivalents per day of correction. So in this study, there was no rate of correlation, or there was no correlation between the rate of rise of sodium and the development of ODS, which was a little bit surprising, but it's been backed up by a couple of large retrospective studies at this point. And the other thing that was a little bit concerning is that in-hospital and 30-day mortality was actually higher with patients who had a slow correction. And again, there's a lot of confounding there. If there's like other reasons that someone's very, very sick and they just have like a difficult to correct serum sodium, like they have other reasons for there to potentially be a mortality signal. But this really sort of, there's more and more evidence that maybe what we thought we knew about sort of correction rates in sodium aren't as important as identifying sort of important risk factors. So in this case, most of them had a sodium less than 110. So again, these are our highest risk patients. The remaining actually did have a sodium higher than 125 on presentation, but notably, all 5 of those patients actually had prolonged periods of hypernatremia after the correction of the hyponatremia. So that's just another thing I now start watching for. Because again, we're talking about a shift from relatively hypotonic to hypertonic, and that's what causes ODS. And so from a practice standpoint, anytime like someone's coming into the ICU and the sodium is less than 110, I do still shoot for like a sort of like 8 or so correction rate. But in the back of my head, I'm more thinking like, yeah, maybe there's not as much data for this. I can be a little bit more liberal rather than just targeting like 4 to 6 and being extra cautious. I do still try and get them more to that 8 to 10 correction window, just because again, maybe there's a signal that slow correction certainly is prolonging hospitalization. It might also be leading to some component of mortality, but again, a lot of confounding. But at least at the very least, in all of sort of these large retrospective studies, it doesn't seem that as long as you're sort of within a reasonable rate of correction, it doesn't seem like the rate of correction itself is super associated with osmotic demyelination syndrome. Okay, cool. Sorry, I know that got a little long, but just reviewing what we talked about today, we talked about an ADH framework for hyponatremia. We tried to understand the physiology of the ADH-independent forms of hyponatremia. We then used that physiology to sort of come up with practical tips for SIADH management, which again, pre-water restriction, augment the solute load, and then see if there's any other sort of like loop diuretics, SGLT2s, any other sort of like window dressing that we can sort of put on there to also help. And then or can talk about patients who are at high risk of overcorrection. Again, any ADH independent form, particularly look out for beer potomania. Those are very high risk patients, both from developing overcorrection. Again, how much that contributes to ODS is unclear, but the concurrent alcohol use, the hypokalemia, those are definitely risk factors for ODS. So keep a lookout for those patients because it's often tempting to give extra crystalloid, extra fluid because they just kind of look unwell and maybe a little bit hypovolemic, but that's actually not the underlying physiology. Cool. And then any questions, feel free to shoot me an email. My email is there. I would love to talk about, yeah, anything. If you're an R3 looking at jobs, please shoot me an email. Any questions about hyponatremia, just, yeah, any questions whatsoever. I would love to hear from you all. And yeah, and hang in there. It's a tough time of year, but you guys, I'm sure, are all killing it.
Thank you so much. If folks want to ask questions, they're more than welcome to. Otherwise, hope to see some folks at office hours at 12 with Sayuli, our inpatient VA chief. But have a wonderful afternoon, everyone.
Oh, and if anyone wants this slide deck, just, oh, actually, I'll send it to you, Will, so that you can distribute. Feel free to use anytime.